So, hello, I have the pleasure of talking about must-know clinical images in nephrology, and I am Annie Lou. A little bit about me, I trained in Maine, and I did my fellowship in Boston and joined faculty afterward. My clinical focus is in geriatric nephrology, and my research focus is on supportive care of older adults with prevalent end-stage kidney disease. I have no disclosures. And so the objectives of today's talk is to recognize classic clinical and histopathologic images associated with common and high yield diseases in nephrology, interpret key radiologic urinalysis and biopsy findings. I will say that for board related questions, that's how I will be aiming for most of the cases today. The topics will include images that we'll be discussing, but for the actual boards, the images tend to be adjunct because they tend not to be first order questions, such as, what is this? And give you a picture. So the images that you'll see on the actual boards will be more to help you to narrow down from the two answer choices to the right answer. Um, the way this presentation will go today is that after a question, I will then pause for 2 seconds and you can pause the video yourself to go at your own pace. All right, so we'll go right into the first case. So this is a 69-year-old woman with malaise, generalized pain, and weakness for the past 3 months. Labs reveal a serum creatinine of 3.8, baseline 1.2 from a year ago, a hemoglobin of 8.9, and a serum albumin of 3.0. A renal biopsy is performed and shown on the right-hand side. What is the diagnosis? A, light chain deposition disease, B, phosphate nephropathy, C, uric acid nephropathy, D, CAS nephropathy, and E, fibrillary glomerular nephritis. Okay. So the answer choice is D, CAS nephropathy. A common distractor in the answer choices here would be A, light chain deposition disease, especially given that these are both plasma cell dyscrasias associated with kidney disease. However, with light chain deposition disease, the light chains actually deposit into the basement membrane. And so you're left with um, nodular glomerular sclerosis, which is not seen in the image. So in this case here, the image is helpful to narrow down to the right answer choice. And we'll go through CAS nephropathy a little bit more. So, a brief background, multiple myeloma is the malignant proliferation of plasma cells involving more than 10% of the bone marrow. Bone pain related to multiple lytic lesions is the most common clinical presentation. And up to 30% of patients are diagnosed incidentally while being evaluated for unrelated problems, where a third of the patients are diagnosed after a pathologic fracture of the commonly of the axial skeleton. So how do CAS nephropathy, how are they formed? Um, it's often due to an overproduction of light chains where the tubulars are, the reabsorption properties of the tubules are exceeded. And this leads to the light chains that filtered and then bind to TAM-Horsfall glycoproteins. And that's also known as uromodulin. They are the most abundant form of proteins in the human urine. And so that combination leads to CAS formation and causing the tubular obstruction and the inflammatory response. The gold standard for diagnosis is a kidney biopsy. And so I include this H&E stain here just to identify a few things. One, that these large pink globs here are going to be what we are defining as CAS formation. And so these fractures that you see here are actually artifacts because of the rigidity of these CAS forming that during preparation, they become these fractured casts. Also, you'll see because of this inflammatory response, inflammatory cells and also macrophages as well seen here. So moving to case two, we have a 44-year-old woman with a history of recurrent kidney stones and UTIs, presented with left flank pain, fatigue, and fever. She had previously undergone percutaneous nephrolithotomy and extracorporeal shockwave lithotripsy 1 year ago for left staghorn calculi. A CT abdomen pelvis was obtained and shown on the right. You have a transverse view and a coronal view. What is the most likely diagnosis? A, renal cell carcinoma, B, xanthogranulomatous pyelonephritis, C, renal abscess, D, tuberculosis, or E, angiomyolipoma. And the answer choice is B, xanthogranulomatous pyelonephritis. A common distractor in this case would be a renal abscess, given her UTI history. However, the difference here is that this would be, in light of the question stem showing a chronicity over time, the renal abscess, you would normally see a well-defined fluid-filled collection within the renal parenchyma that you do not see here. Instead, you're seeing a dilated renal pelvis and calyces. So I left this paw print as a hint, and we'll go directly to the topic at hand. So xanthogranulomatous pyelonephritis was first described in 1916 as a rare destructive granulomatous inflammation. It is a little over 0.5% of all chronic pyelonephritis cases and more prevalent in women. And this is due to chronic urinary obstruction. Okay, so the presentation in this case would be flank pain, fever, weight loss, anorexia, as we would expect in pyelo. And then on CT, see this enlarged segment of the kidney, poor or no excretion of contrast into the collecting system. And then, as mentioned, dilated and enlarged renal pelvis and calyces, giving this multiloculated appearance. And that's actually radiologically called the bear paw sign, which next to here, you can see how that got its name. Okay. Moving to case three, we have a 58-year-old man with a 12-year history of type 2 diabetes with an A1C of 8.2, hypertension, hyperlipidemia, and CKD stage 3B, with a urine albumin to creatinine ratio of 0.5 gram per gram. The patient is managed with lisinopril 40, amlodipine 10, furosemide 40, all per day. And on exam, blood pressure is 132/60 with a heart rate of 70, and also found to have trace to 1+ edema in his lower extremities. So, which of the following is the most appropriate next step in management? A, no changes to therapy are needed other than optimizing glycemic control. B, initiate an SGLT2 inhibitor and consider adding a nonsteroidal mineralocorticoid receptor antagonist. C, a referral for kidney transplant evaluation. D, perform another kidney biopsy to confirm the diagnosis. E, an angiotensin receptor antagonist to his current regimen. And the image on the right is a biopsy from a year ago. Okay. So the answer choice is B, initiate an SGLT2 inhibitor and consider adding a nonsteroidal MRA. And so a distractor here would be answer choice A. On the biopsy from a year ago, you can see nodular sclerosis, and in this case would be related to diabetic kidney disease. And so, though choice A includes the need to optimize glycemic control, which is important and relevant, this patient has progressive kidney disease along with albuminuria, puts him at risk for developing end-stage kidney disease if this was left untreated. And so, all the more reason why SGLT2 would be most relevant here. So I do have this slide in here just as a question stem breakdown. This just to summarize this patient having a longstanding history of type 2 diabetes, it being uncontrolled. He also has other risk factors like hypertension, hyperlipidemia, a moderate level of albuminuria, and he is maxed out on lisinopril. So in terms of for diabetic kidney disease, first-line therapy being maximally dose ACE inhibitor or ARB, and this goes to one of the answer choices where a combination of both increases the risk of hyperkalemia and acute kidney injury. So SGLT2s are strongly recommended for diabetic kidney disease with albuminuria, regardless of glycemic control. That's after two large studies. And then nonsteroidal MRAs offer additional renal and cardiovascular protection in patients with type 2 diabetes and diabetic kidney disease. So just a comment here on SGLT2 inhibitors. This is from the KDIGO 2024 Clinical Practice Guidelines for Evaluation and Management of CKD. And so this is a level 1A recommendation in treating patients with CKD, and this is without with a comment on an EGFR of greater than or equal to 20, and also a degree of albuminuria. In patients with heart failure, irrespective of their level of their albuminuria, SGLT2 would still receives a 1A level recommendation. And so, also in light here, they also suggest treating patients with an EGF degree of CKD with minimal to no albuminuria with the SGLT2 inhibitor. And as mentioned here, this is a level 2B recommendation. Moving to case 4. So we have a 62-year-old man with type 2 diabetes and hypertension. He's hospitalized for disseminated herpes zoster and is started on intravenous acyclovir. On hospital day 2, he develops nausea and right flank discomfort. Vital signs are stable. Urine output has decreased, and repeat labs show a serum creatinine of 2.4 when his baseline is 1.0. A urine sample is sent for microscopy and as shown to the right. Which of the following is most likely cause of this patient's acute kidney injury? A, acute interstitial nephritis, B, acute tubular necrosis, C, obstructive crystal-induced tubulopathy, D, prerenal azotemia due to volume depletion, or E, uric acid nephropathy. Answer choice is C, obstructive crystal-induced tubulopathy. So a distractor here would be uric acid nephropathy in light of the needle-shaped crystals as seen here, and also having birefringence as well. However, in this case, this patient has no aspect in the history in the question stem of having a hyperuricemia state. So if and when you have to make a leap to get to that answer choice, it's most often a distractor. So acyclovir-induced nephropathy. Acyclovir is renally excreted, a large proportion of that, as you can see there, via the glomerular filtration tubular secretion. And so in states where there's low urine volume or volume depletion, this drug can precipitate as needle-shaped crystals, leading to tubular obstruction and AKI. Okay. So the next case is a 39-year-old man with end-stage kidney disease experiencing homelessness presents to the emergency department with anorexia, nausea, fatigue, oliguria, and pruritus. 5 months early, he had stopped attending his regular hemodialysis sessions, and on exam, his blood pressure is 167/80, lethargic, slowed speech, and has lower extremity edema, and his breath has a urine-like odor. What of the following is the most likely diagnosis? A, retention keratosis, B, uremic frost, C, eczematous dermatitis, and D, post-inflammatory desquamation. Answer choice is B, uremic frost. Now, for each of these, they all have, it's a dermatologic answer choice. But the key thing here is that the one that is most associated with kidney disease would be uremic frost. And we'll go through that in just a second. So this was first described by Dr. Hirschsprung in 1865. It's a manifestation of severe azotemia and presents as tiny yellow-white urea crystals deposit on the skin, and that's what gives it that frost-like appearance. It's most commonly seen on eccrine glands and can be easily wiped away. This nowadays is less common due to the availability of dialysis. However, in areas that are resource limited, this may be more commonly seen. So, among 9 cases of uremic frost published, the mean BUN was nearly 200, and the mean creatinine was a little over 17. So, for the next case, this is similar to what I mentioned about first order questions. The urine sediment shown is associated with which genetic mutation? A, SLC3A1, B, PKD, C, COL4A5, D, NPHS2, or E, UMOD. Okay. And the answer choice is A, SLC3A1. So the key thing here, this is technically a second order question because one, you have to identify what is on urine sediment here in terms of this hexagonal crystals that are translucent and white, and then to be able to know then what genetic mutations related to that. So um, this type of crystal is a cysteine crystal. Cystinuria is a rare disorder, if you look at genetic causes of nephrolithiasis, this is one of the more common ones. It is autosomal recessive and is caused by mutation in SLC3A1 or SLC7A9. So these genes encode two parts of the transporter controlling renal tubular reabsorption of dibasic amino acids, such as cysteine. And so, as you can imagine, with this genetic defect, then the tubulars are not reabsorbing these amino acids as well. And then that leads to an increase in the amount that is in the urine. Cysteine itself is poorly soluble at like typical urine pH, and that leads to stone formation. Okay, so we'll move on to the next case. And that is a 22-year-old woman presents with arthralgias, abdominal pain, and rash on her lower extremities. Vital signs are stable and a serum creatinine of 0.8. Urinalysis shows 2 plus blood, 1 plus protein with microscopy as shown in the bottom right, and a fecal occult blood test is positive. What is the most likely diagnosis? A, renal cell carcinoma, B, renal infarction, C, nephrolithiasis, D, anti-GBM disease, or E, IgA vasculitis. And the answer choice is E, IgA vasculitis. A distractor here could be also anti-GBM disease, given that the patient also was found to have blood and protein in her urine. However, one, her creatinine is normal, and also typically on boards, an anti-GBM process could be associated with also pulmonary findings as well, which was not stated in this question stem. So for IgA vasculitis, formerly known as henoch-Schönlein purpura, not only on the lower extremity image here, you see the purpura that would be expected to be palpable, but also the dysmorphic RBCs, also in the question stem, arthralgias, and then there was GI involvement as well. So in terms of on the left side, the light microscopy does show mesangial proliferation. That's due to increased mesangial cellularity and also in the matrix. Here with the arrow, you also see a crescent formation. On the immunofluorescence on the right, you commonly see this lumpy, bumpy, granular appearance, and that's due to the dominant or codominant IgA deposition in the mesangium. Okay. So for the next case, this is an image on the left of a plain film. And what is the most likely diagnosis? A, renal tubular acidosis, B, primary hypoparathyroidism, C, familial hypocalciuric hypercalcemia, D, salicylate overdose, or E, Paget's disease. And the answer is A, renal tubular acidosis. So in this plain film, you'll see that there's bilateral calcifications of the renal parenchyma, and it spares the pelvis in the center here. So this was a case that had been published that was of a patient who was diagnosed with renal tubular acidosis at 9 years of age, but did not undergo medical follow-up for 20 years. The other answer choices actually did not have are not common causes of nephrocalcinosis. And I will comment here specifically that distal renal tubular acidosis is of the RTAs associated with nephrocalcinosis. Okay, so for the next case, a image on the left, and the most likely diagnosis is A, idiopathic focal segmental glomerular sclerosis, B, diabetic nephropathy, C, membranoproliferative glomerular nephritis, D, microscopic polyangiitis, or E, anti-GBM nephritis. Okay. So anti-GBM nephritis. And so one of the key things here is you're presented with an immunofluorescence. There's a strong linear pattern here, and that is tied to the glomerular basement membrane staining of polyclonal IgG. And in most cases, you also have a C3 positive staining as well. Okay, so just a little history on anti-GBM. And so Dr. Goodpasture was a resident at the time at MGH pathology department. And when he reported these autopsy findings in young sailors, then in 1958, they used the term Goodpasture syndrome to identify the lung findings and the renal findings as well. And then in 1964, that's when uh, Dr. Shear and Grossman reported the linear stainings that you had seen on immunofluorescence. So for anti-GBM antibody glomerulonephritis, the incidence is 1 case per million per year in the US, and that's 1 to 2% of renal biopsy specimens. There is a bimodal age distribution where it's one segment is the late teens to 20s, and then the 50 to 70-year-old patient population. There's a very slight predominance in males, and as mentioned, there's a strong correlation association with upper respiratory prodrome, along with anemia, and then the severe kidney injury in a matter of a rapid progressive glomerulonephritis pattern, and also microscopic hematuria. So this is a light microscopy view, as you can see here, and we're just going to zoom in on one of the glomerulus. So as you can see here, this is a Jones silver stain, excuse me, and that stains specifically for collagen and basement membrane. And so in this glomerulus here, there's thinning to no of the stain, and that highlights the anti-GBM disease. Okay, so for the next case, this is a 40-year-old man with chronic kidney disease, baseline creatinine of 1.5, who presents with weakness, fatigue, an episode of palpitations. His medications include furosemide 40, lisinopril 20, atorvastatin 20, and an aspirin a day. Based on his ECG, what is the most likely diagnosis? A, hypomagnesemia, B, hypokalemia, C, hyperkalemia, D, hypocalcemia. And in the next slide here, I'll have a larger view of the ECG so you can take a better look at it. And then we'll go back to the question. And so the answer here is B, hypokalemia. So one of the key aspects of hypokalemia, as you can see in the image on the right specifically, you not only have a slightly prolonged PR interval, and also a slight ST depression. But one of the key features is this prominent U wave, and that's how you can eventually progress as well to worsening arrhythmias. And so back to this image here, one of the key things I think you'll be able to see and appreciate the most, if you can see my pointer, is that you have your QRS, T, and then these U waves that are appearing with increasing amplitudes. There's also the T wave flattening that is less seen here, and then ST segment depression. But this has an increased risk of PVCs and supraventricular and ventricular tachyarrhythmias. Okay, so moving on to the next case. This is a 64-year-old woman with end-stage kidney disease on intermittent hemodialysis who presents with a painful ulcerative skin lesion on her thigh. She reports it began as a reddish rash and ulcerated over a few weeks. Which of the following is the most appropriate next step to confirm the diagnosis? A, MRI of the affected limb. B, wound swab for bacterial culture. C, skin biopsy. D, serum protein C and S levels. Or E, lupus serologies. This patient has calcemic uremic arteriolopathy, which is also known as calciphylaxis. And this occurs up to 5% of patients on dialysis, with a classical presentation of the skin lesion that then can progress to a violaceous painful plaque. And as we all know, this is commonly known as calciphylaxis. The differential of this includes necrotizing fasciitis, pyoderma gangrenosum, and coumadin necrosis, and also systemic lupus. And so this carries a 1-year mortality between 40 to 80%, and a skin biopsy is the most helpful to differentiate from the above because it confirms arteriolar calcifications and mural thrombus. Okay, so we'll move to the next slide. And so for this case, we have a 68-year-old man with a history of hypertension, type 2 diabetes, and coronary artery disease who presents for a follow-up. His current medications include amlodipine and lisinopril, which was initiated 4 weeks ago. And on exam, his blood pressure is 162 over 94, a serum creatinine of 1.7 versus 1.3 2 weeks ago, a potassium of 4.8. A urinalysis shows 1 plus protein, no hematuria or CAS. There's a renal duplex ultrasonography that's shown on the right. Which of the following is the most appropriate next step in management? A, discontinue lisinopril and initiate hydralazine. B, continue lisinopril and add thiazide diuretic. C, refer for immediate renal artery stenting. D, add spironolactone for improved blood pressure control. Or E, discontinue lisinopril and initiate clonidine. Okay, and the answer choice is B, continue lisinopril and add thiazide diuretic. So we'll go more into this ultrasonography in a second. But the waveforms here will be a clue as to the renal artery stenosis that it's driving at. In terms of management for this patient, the other aspects would be that the serum creatinine, though, did go up. The increase is close to proportion of what would be expected given his recent initiation of lisinopril. And so, though this patient did not have resistant hypertension, he would be getting close to it. And so, a resistant hypertension is defined as blood pressure is not at goal despite 3 different classes of antihypertensives at its highest tolerated dose, with one being a diuretic. And so patients with resistant hypertension are nearly 50% more likely to have a cardiovascular event and 25% more likely to develop kidney failure than those with hypertension that is not resistant. So as I was alluding to earlier, it's common about renal artery stenosis. It's common among patients with resistant hypertension, especially older adults who have vascular disease or a smoking history, diabetes, and chronic kidney disease. The duplex ultrasound is the most common initial imaging given its cost effectiveness and also high pretest probability. So as you can look at these waveforms, the classic presentation for renal artery stenosis is a tardus parvus waveform. And if I have any Latin scholars out there, you know that the tardus is for slow, and that's why you have a longer waveform here, and parvus being small, meaning a shorter amplitude. So, in terms of revascularization in atherosclerotic renal vascular disease, in the 1960s, surgical revascularization of the kidney became standard therapy for selected patients with renal vascular hypertension. And then this later expanded to in the 80s to endovascular revascularization with stent implantation. Then, three randomized control trials, as mentioned here, directly compared stent placement with medical therapy versus medical therapy alone. And that changed a lot of the management because the renal vascularization did not consistently lower blood pressure or restore kidney function or prevent cardiovascular outcomes more effectively than medical therapy alone over 3 to 5 years. This still remains controversial, given that the limitation has been cited as under-enrollment of the most hemodynamically significant renal artery stenosis. So for this patient, the next step would be to up titrate his medications as opposed to going to stent placement. So the take-home messages I have here be like images and question stems are helpful adjunct to narrow the answer choices to the correct one. And also highlighting the importance of urine microscopy findings on boards. I provide my references here. And also, I just want to comment here. We did talk about DAPA CKD and EMPA kidney briefly in the question stem, but one of the ones I want to highlight is this secondary analysis that came out of EMPA kidney that targeted empagliflozin and reduced progression of CKD in different subgroups of patients with CKD, and that's including patients without albuminuria. So this was a very helpful change for to include this patient population into the trials that did not have diabetic kidney disease. So I thank you all for your attention, and feel free to let me know if you have any questions. Thank you.